All right. We are going to go over GI and urologic problems tonight. As I said, this is it's almost obscenely short. 45 slides when you take out the fillers, like the reviews and the first couple of slides, only 45. So probably not even going to take a break. We'll see. We'll see how much I get sidetracked because there's a couple things with it being that short. I don't know that it's going to say everything that I want to say, so I may add some stuff into it. But before we get started, is anybody struggling with some of the stuff that we've went over? This is the module that becomes information overload, especially for cardiology. Like I said, I geek out to it, but when you're learning it for the first time, this is pretty hard stuff. Airway trips up a lot of people. And airway is one of those deceptive ones too, because it feels like you got it until you get to the registry and you find out you don't got it. So if there's any questions, we can cover that before we get into the short little blurb tonight. Otherwise, we'll move right into it. Okay. All right. So tonight we're going over GI problems. We're going to talk about the typical stomach ache and pretty much any problems that happen from mouth to, well, not anus, but we'll cover that. We're also going to cover some urologic. So pretty much all starting from the entrance going all the way to the exit. That's what we're covering tonight. A lot of it is going to be your anatomy, knowing what you need to do, or at least what body systems are what. That way you can remember how things go through. It won't be too much like a college anatomy class. We won't really be getting into how things work, but I do want to mention a couple of things because I want you to understand how your medications work if you give them by mouth, for example. So abdominal pain is very common. You're going to get this a lot more often than you really think or care to get it. And sometimes it's bogus. Sometimes it's not. Like I had a call. Like I said, I don't like to go into war stories, but I did for this. I remember one call back when I worked for AAA. We woke up at like 4:30 in the morning after being up past midnight running car wrecks, a structure fire, and stuff that really did keep us on our toes. We got to woke up at 4:30 in the morning to go to this patient's house because he had severe stomach cramps, stomach pains. Called 911, said they were the worst of his life, everything, to the point where the dispatcher was relaying this to us. And we get there, and he's sitting out on the front steps of his house. Doesn't look like he's in any pain at all. We don't even think he's the patient. That's how calm this guy is. So we get out, and he's like, "Hey, I'm the one that called. Turns out my stomach ache ended like 3 days ago, and I've been fine ever since, but I want to go get checked out and see." So sometimes you're going to get calls like that. It sucks. But that being said, there's a lot of things that can go wrong that are legit emergencies, and we want to be careful that we don't get complacent, because you get a bunch of those calls and then you start to expect them, and then you get the guy or the girl that's actually got appendicitis, or an enlarged, possibly ruptured spleen or something like that could literally kill them. And we underestimate it because we're too used to the bogus ones. I would like a deeper discussion about the aortic aneurysm. Okay. All right. So before we get into this, let's talk about that. I'll start with, what do you not? Where do you struggle with it? Yes, I am talking. Hold on a second. Let me type that to him. Can y'all hear me in general, just to make sure that this isn't a problem on my side? Okay, so making sure. All right. Yeah. Audio issues. Okay, so let me get back to this. Deeper discussion about the aortic aneurysm. It just looks like it's hard to see that in the patient. Okay, yeah, so aortic aneurysms are pretty hard to find in a patient. There's a couple of things that will really like red flag say, hey, that's what this guy's got. Um, but unfortunately, a lot of it is subjective. It really just depends on keywords that they tell you. Like for example, at least as far as in school, you guys need to know that if you hear that your patient says there's a tearing sensation, it feels like they're being ripped apart. Um, that's kind of like that impending doom that we talk about in heart attacks. That is it's a statement from them um, that is really a telltale sign that they have some kind of an aneurysm going on. Because the only real place in the body that gives that sensation. And those aneurysms, if we here, I'll tell you, I'm going to put a picture to kind of make more sense about this. Give me a second. I'm going to log in on my iPad.
Is that all right if I talk?
Yeah, that's right. Go ahead.
Well, it looks like there's a bulge. It says that there's a bulge, right?
Correct.
By the navel, right? Does that actually happen?
Yes. So it's like an egg on the side of a tire. The structural wall, and like I said, once I get to where I can draw a picture, I'll show you. But it's a true weakening because your aorta is pressurized just like a tire. It's just hydraulically pressurized, not pneumatically. So
And
when the wall,
I'm sorry.
no, you're fine. Just when the wall weakens in a certain spot, it will bulge because that pressure is pushing out on it.
Well, my wife's a ICU nurse, and I was asking her about this. And she's like, a doctor told her years ago, check the pedal pulse, and sometimes if there's no pedal pulse, then that's a good indication that's might be what happened. But again,
So when you're checking the pedal pulse, if it's an aneurysm, they might still have a pedal pulse. But what you will notice is that if you check both of them, you're going to see a difference in either the left pulse or the right pulse. It's the same thing as if you were to check two radials. It just depends on where that aortic aneurysm is at. If it's abdominal, then you're not going to see a difference in your radials, right? Because the problem is further past where the brachial arteries take off. If it's a thoracic aneurysm, then you might actually see the problem in the wrist. So I'm almost to where I can draw the picture and then I can make more sense of this. In let's make presenter. All right, bear with me. There we go. Whiteboard. Okay.
well, I mean, sorry, everybody. This aneurysm thing just freaked me out when I was looking at it. So
Hey, no, that's fine. It's perfectly fine. Like I said, tonight's a very short chapter, so we got all the time in the world to go over things that you guys are struggling with. All right. So here's your heart, and your aorta does this essentially. So it comes up, whoop, and then it comes straight down like so. It branches off. These aren't legs. This is your aorta. All right. Goes down to three. So that goes down to your femoral arteries, down your legs. But here at the top, you always see these little offshoots at the top of the aorta, right? So one goes up to your carotids, and then these go off. I draw like crap. I know. I'm sorry. Anyway, so these go off to your arms. So basically, your aorta could look like a stick figure. Um, Depending on where the problem is at, you're going to see issues in this. So, like, let's say, first of all, here's two examples of a problem with the aorta. All right, this is the dividing line. So the first one at the top, this is how they usually start. All right, you get this little section of the wall that comes loose, and blood flow is getting whirled up in here. All right, it's actually disrupting the flow of blood. So where this little offshoot is, it's catching the blood. So the normal blood that flows down here is only getting around on this left side. The tearing sensation that people say is because they can feel every time that heart beats, they can feel that flap ripping further and further off the inner wall. Now, the issue with that is that once the let me see how I don't think I can erase. Once that little tear starts on the inside, now that is mass that is no longer attached to the edge of the artery, right? So the pressure that's in the system, now that particular spot in the wall is no longer thick enough by design to maintain its integrity with the pressure of the blood that's in it. Because remember, your aorta is massive, massive amounts of pressure. It's the main pipeline. So over time, first of all, you're going to have this tearing, right? That's bad enough as it is. But eventually, you're going to start to get a bubble. Just like on a tire that's got a weak spot in the wall, right there. Let me see, there's got to be a way for me to erase. Nope. I say there is. Could be wrong. All right. Anyway, so imagine that straight line isn't there anymore. Now you've got this bubble on the right. So you've taken a thinner wall because of that shearing that you see at the top, and now you're bulging it, which means that what's left is now being spread even more thin. If that pops, then your patient's pretty much dead, because the amount of blood flow that they're gonna lose by having a hole right there it's enough to bleed out in like 6 seconds. So the issue and what you're talking about with the pedal pulse, and I mentioned radial pulse, is where in the aorta is that going to be? If it's up here at the top, to get my drawing. There we go. Kinda. All right. If I'm up here in the top, it's really, really thin now. See up there in the arch, if it's up there, first of all, that's even worse because you're even closer to the left ventricle where the pressure is the highest. The pressure drops as you get further from the heart, just because you're further from the pump. So if it happens there, you're much more likely to have a rupture. However, if it's up there, you're more likely going to see a difference in one side versus the other, because when you disrupt the blood flow and part of that aorta, it's not a complete block. But when you stick something in the way of what should be moving very fluidly and in a straight, efficient line with nothing blocking it, there's no turbulence. There's no whirling around or anything like that. Everything is moving in the same direction. But when you have that bulge or that shear, it will disrupt the blood flow, typically on one side, wherever that's at. So if it's on the left side of the aorta, you're going to feel a diminished pulse on the left side of the body because the pressure is getting held up. The pressure drops faster. You can sometimes feel that in the strength of the pulse. You can see it in blood pressure. If you take a blood pressure on both sides of the body, you'll get two different numbers, two vastly different numbers. If the problem is down here in the abdominal area, then your radial pulses will be fine because at that point there's no disruption in flow. But then you're going to have a problem down here at the femoral, at the pedal pulse side. So it really just depends on where the problem is at. Does that help? Still with me? Did I lose you?
No, I got you. It's just a freaky type emergency. It just it just when I'm reading about it, it's kind of scary. So
And
you
it
know,
absolutely is because your patient, first of all, is going to be screaming in agony. Like this is not a I'm slightly discomfortable. Like this is I feel like I'm being ripped apart. That's usually how people describe it. They feel like there's two invisible hands inside of them and it's ripping them in half. So it feels about as scary as it looks. The good thing
and
is,
how long?
go ahead.
Like if you, like I mean, if it hasn't completely ruptured, you know, how long really does a patient have? If you think this is the problem and you're rapid transporting them, how you know,
It,
like our hospital is pretty pretty bad, and they would have to fly. There is no cath lab or really no cardiology, so
yeah.
they would have to fly out.
So,
If something happened to me, I would have to go to Memphis or Little Rock.
right. And that's the thing. So those where you're at, if your patient is able to still breathe and talk to you, then they're about as stable as they're going to get without an actual surgery. So there's really no sense in stopping at a lower level trauma center anyway. They need surgery and they need it as fast as possible. Like it would be phenomenal if we could put a surgeon in the ambulance for these things, but that's just it's not feasible. As far as how long they have, it really depends on how long they've had the problem and how bad is it. And we don't know that. We can't see that in the field. That's something that we would never be able to gauge. Short of getting a CT scan in the back of the truck. But you could say if they're telling you that it's hurting really bad, I mean, it could still technically go days before it ruptures. Eventually, it will rupture if it doesn't get fixed. Um, but it just depends. That's a hard question to answer. Usually, I mean, the best thing I can tell you is if you encounter this, don't worry too much about. It's not like a stroke where you got to worry about time. All right, because pretty much the answer is as soon as possible to whatever. So as soon as possible, get them to a at least level 2 trauma center. And if it is a level 2, let them know ahead of time because that means that their surgeons, their neurologists, and all that they're not necessarily in the hospital, but they are on call. So if this is what you're encountering and you're going to a level 2 trauma center, you can actually call ahead and say, hey, we're going to need surgery. We're carrying in a possible aneurysm, aortic aneurysm. And once you tell the ER that, they'll know exactly who to call. But that gives them time to get the people in the building so that when you arrive, they're not starting their trip at that point. Um, yeah, I mean, that's pretty much it on that. But like I said, depending on where it is, because your aorta is long, we only really ever see, and if you look at the heart, you only ever see the upper arch, but it goes all the way down past your belly button before it splits off. So an aneurysm can happen anywhere in there. And then the problem is going to be anywhere below where the aneurysm is at. So, if it's at the belly button, then no, it's not going to affect your radial pulses. It's going to affect everything below it. Any other questions on aneurysms or anything else? Cool. All right. Let me get presenter switched back where it needs to be, and we'll continue with tonight's lecture. Okay. So make sure, yeah, all right, everything's facing. All right. So like I said, abdominal pain, you're going to get these calls and they're very, very broad. It can be any number of things. And I'm glad you actually brought up aneurysm because that can come across as an abdominal pain and it has absolutely nothing to do with your GI tract. But depending on where they're hurting, if they're hurting between the, the diaphragm and the waist, they're going to say it's abdominal pain and it can be any number of things in there. So tonight we're going to focus on the GI tract and the urologic system. It can be pretty difficult to identify what's wrong. So as an EMT, you do not have to determine the exact cause. That's not really your job, right? We don't diagnose. We want to rule out a couple of things, or not really rule out, but be aware. We want to look for a couple of things because if we determine that it's any of that list of things that we're looking for, the pucker factor should go way up. But other than that, we're pretty much going to do supportive care and get them to the hospital. You should be able to recognize all life-threatening problems and act accordingly. All right, so for your anatomy review, the abdominal cavity, which is separated from the thorax by the diaphragm, so everything below the diaphragm. You have the GI system, which is your liver, your stomach, your small intestines, large intestines, all that. You have your genital system and your urinary system. It is a mix of solid and hollow organs, and that can, depending on what's wrong, that can definitely change what you see with your patient, right? Let me ask you this. Which one of these do you think would bleed more, for example? I mean, like I said, I know we're not in trauma yet, but just thinking about it. A solid or a hollow organ, which one do you think's got more chance to do profuse bleeding? Good, solid. All right. So what's the problem with hollow organs? Should we worry about them? If bleeding is not the issue, what do we worry about with hollow organs? Well, y'all are on it. Their contents, right? We don't want the gallbladder, or rather, we don't want the appendix or the pancreas. We don't want them not, spilling all their stuff into your abdominal cavity, because then we run into the problem of sepsis. That's why we don't want the appendix to burst inside of somebody's body. We really don't want the spleen to burst in somebody's body. Those are major problems. So your solid organs, we have the liver, which is our filter. That's an easy way to put it. It does other things. You as EMTs need to know that it stores glucagon, right? That we use as a backup. It processes into glucose if we need it. So that's a buffer. We have the spleen, the pancreas. The pancreas creates insulin, which we'll get to in one of the next couple of chapters. Your kidneys, which are your filters, not just for urinating out just water that you drink or anything like that. Your kidneys are good for pH balance. They're good for hydration balance. They keep a certain amount of hydration in you, but they also regulate certain electrolytes that we need to keep in balance. Like for example, potassium, right? If you guys have ever heard of the conditions hypokalemia or hyperkalemia, usually the problem with it getting high is the kidneys are failing. So That being said, if we flip that around, if the kidneys are failing, that's one of the things we have to watch out for. So you really see that problem a lot with dialysis patients. And then you have your ovaries. Those are solid organs. Injuries to a solid organ, like we said, they can cause shock and a lot of bleeding. That's a major problem. Even though it's going to be internal, unless it was like a penetrating injury, you're not going to see it. All that blood, your abdominal cavity can hold all of the blood, or at least way more than enough blood for you to actually to die from it. And you'll never lose a drop to the ground. All right, for your hollow organs, you have your gallbladder, your stomach, small intestine, large intestine, your urinary bladder. And if there's a perforation of any of these, the problem is that we're going to lose those contents and they're going to contaminate the abdominal cavity. And that's a nightmare to try to fix. All right, here's just a picture of where things are located. One of the things I want to point out, because I've seen it, I've actually seen medical books. I think my EMT book did this wrong. The liver does not go all the way across the body. All right, it is a right upper quadrant. The gallbladder is a tiny little piece. You don't even see it. It's under. It's kind of tucked away under the liver, above the kidney. You have your pancreas and your spleen. So if somebody gets hit in the left upper quadrant, their spleen is in trouble. If somebody gets hit in the right upper quadrant, their liver is in trouble. And if they get hit in either one of those, they are in trouble. But that's just, keep that in mind. You have your ovaries at the bottom if you're a female. On the right hand is your hollow organs. So take that as it may. Notice your stomach is kind of on the left upper side, mostly because it's at the same level with the liver. So it's got to be moved over to one side or the other. And we're going to talk about the stomach. There's a lot of stuff I want y'all to know about that and how medications will affect you, that kind of thing. All right. So for the GI system itself, the main goal of this is just to digest your food and pull energy from it. This starts when you start chewing your food, right? Because you're physically breaking it down. Your saliva gets into it, and the enzymes start to break it down on a chemical level, so that by the time you swallow it down your stomach, you already started the process. The stomach is the main digestive organ. That's where, think about what's inside your stomach. What's the main thing that's inside your stomach that helps break down the food? Acid. Anybody know what kind of acid? What it's called? Hey, you're not wrong. And actually, your book only just says digestive organs or digestive fluids, but it's no bile, not bile, but bile is made in the liver. The acid in your stomach is hydrochloric acid. It's actually the strongest acid on the planet. Yet we walk around with a little balloon full of it, and we're perfectly fine all day, right? Um, so, but the reason that I brought that up is because I want to bring up medications tonight, just in case the slides don't go into it. Because I had this conversation with somebody earlier today about like ibuprofen and why do we take medications with food? What's the purpose of that kind of thing. Moving on, we'll get to it. Your liver also assists in digestion, right? It secretes bile, which aids in the digestion of fats. So lipase is in there. You don't need to know that, but if you're an overachiever, if you just want to know what it is, that's one of the chemicals that breaks it down. Bile is not something we want chilling out in our body. We usually get rid of that. So if somebody's got liver problems, they're probably going to have an excessive amount of bile in the blood. But it is something that we use. We need it. We just don't want to keep it floating around in us. Your liver filters toxic substances produced by digestion. It also filters toxic substances produced by ingestion in nice short glasses. The cool thing about the liver is that it regenerates. It's the only organ in the body that will, if you take a chunk of it off, it will grow that chunk back, which is pretty cool. It doesn't just seal up or anything. It will regenerate as long as it's healthy. This does create your glucose stores as well. It produces substances necessary for blood clotting and immune function. So again, think about it. When somebody's got hepatitis or cirrhosis of the liver due to alcoholism and that kind of thing, these are the things that you're going to start to see. Oh, don't need to drop F-bombs in the class. You're going to see these things mess up, right? So they might have a problem with their glucose. They might have a problem with blood clotting. These are when the liver starts to fail, they're going to start to lose some traction on these systems functions. And it says here the gallbladder is a reservoir for the bile. The two systems work together. That's one of the reasons why your gallbladder is right up underneath your liver. So once you've passed the stomach, the food's going to go into the small intestine, which consists of 3 sections. You have your duodenum or your duodenum, however you want to say it, potato. This is the first section of your small intestine. Your digestive juices from the pancreas and the liver mix together here. The pancreas secretes enzymes that break down starches, fats, and proteins. The big thing that I want to say here is that this is where a lot of your pretty much everything that we try to ingest has to go through what we call the pyloric circulation. So, I'm sorry, portal circulation, not pyloric. You have portal veins, portal arteries. They pretty much run off the liver, and that is how they filter. So when we give a medicine, the reason that it takes so long to take effect is because it has to, first of all, it has to break down, right? Then it has to get through the portal system. The portal system is trying to clean that stuff out. That's not what we want the body to have. Our body doesn't want Tylenol to just kind of chill out in there forever. So the liver breaks it down. Tylenol tablets, and all those other pills are designed to, even though the liver breaks them down, they're designed to last a while through that circulation as they continue to get through the liver and broken down again. They continue to go back through the liver and broken down again until they're eventually gone. They're designed to, they call it a half-life. So a medicine is designed to go through that X amount of times. It stays in there, and then that's how long they determine that your therapeutic range. So they look like Tylenol for a headache. Takes about 30 minutes to get enough of it in your system to relieve the headache. But as it's in your system, the liver is constantly trying to get it out. And eventually, it's going to get below that therapeutic range, and now you don't feel it anymore. So that's why, like, sometimes you'll get a medication or a prescription that says, take it every 6 hours. That's about how long they expect it to last. But that's what's happening here. Your food goes through the same process, and the alcohol you drink goes through the same process. If you eat a quarter or a penny, it's going to try to go through the same process, but it resists. Obviously, you don't digest a quarter. But everything you swallow goes through this process, or at least it attempts to. The next spot is your jejunum. If you've ever been punched in the jejunum, that sucks. This plays a major role in absorption of digestive products, and it does a lot of the work in the small intestine. This is the bulk of your small intestines. All right. Once you get past that, you're down to the ileum, and you're getting pretty low. If you've ever looked at like the terminology, you ever consider the names of things in an abdomen? You have your iliac crest, your ischium, your ileum. All these things are way down at the bottom, right? So your ileum is way at the end of the small intestines, is down at the bottom of your abdomen. This absorbs whatever nutrients weren't absorbed earlier, so it pretty much just picks up the last of the bottom of the barrel. And this is where your bile acids are absorbed so that they can be returned to the liver for future use, and the vitamin B12 for making nerve cells and red blood cells, because those typically last the longest. They're the hardest to pick up. It takes about that length of intestine to get them broken down enough that they can be absorbed. All right, so at this point, now we've pretty much your small intestines pretty much picked up all the nutrients you're going to get from your food. So now it's time to get rid of the waste. That's where we get to the large intestines. So food that's not broken down comes here, and peristalsis moves waste through the intestine. Anybody want to tell me what peristalsis means? I'll give you a hint. This is not the first time it happens in your digestive tract. Yes, good. So peristalsis is basically um, whenever there's pressure put in that particular spot, it pushes. So if you swallow a piece of steak or whatever, that's what moves it down your esophagus. Because think about it, your esophagus is not that big, right? Something's got to push it, otherwise it's just going to hang out there. Peristalsis is what moves everything through your digestive tract. At this point, we're just pulling out whatever water we can get from it so we can stay hydrated, and stool is formed. And after that, it just passes out. It goes to the rectum and on out through the body. Some other players in the game, you have your spleen. It's located in the abdomen, but it doesn't really have a digestive function. Okay, so it's interesting. The spleen is part of the GI tract, but it doesn't actually break the food down. Anybody want to take a stab at what it does? And I'll say this too. With us cooking food better and being more sterile in our environments and stuff, our spleens are actually getting smaller. There's a hint for you. If we don't go back to eating raw meat and stuff like that, there may come a time where we don't even have a spleen. It does. It is on the slide. Something I'm looking for, though, is not on the slide. The last line, produces antibodies, kind of hints at it. It's all right. All right. So the spleen is basically an encyclopedia of pretty much everything that you've ever come in contact with that the body deems to be a threat, right? So anytime you get sick, and those antibodies are created, they're created by the spleen. Anytime you eat food or you get food poisoning, your your spleen is what's responsible for basically making sure that that doesn't happen again. It does produce antibodies, but it also keeps a store of why those antibodies are there, so that if you encounter something again, say you get sick, some kind of food poisoning, not E. coli, because we can get E. coli multiple times. Um, you get sick and your body flushes it out. You kick it, obviously, because we don't stay in food poisoning forever. So your body produces antibodies. The next time you encounter something that the body deems a threat, the first thing it does is it looks, the spleen activates and basically says, have I had this before? If yes, cool. I'm going to release all these antibodies, and we'll just kick this out, kick this to the curb right here with the antibodies. No problem. We've had this before. We know how to fight this fight. The spleen, if you haven't encountered it, then it has to work more with the immune system to fight it off, and then it builds the antibodies based on it from there. So now you can see why it's a bad idea, or why it's not good for a patient if the spleen ruptures. Is because, anybody seen Ghostbusters, the first one? Yeah, this is a good time of year to watch it too because it's almost Halloween. So when they shut the building down in Ghostbusters and all the ghosts escape, it's basically what happens when your spleen ruptures. All that crap you've ever been um, exposed to. No, it's not stored. It's not like you're keeping coronavirus inside of you, but the way that the body remembers it, if that spleen ruptures, you're gonna have some serious problems because of that. That's just the nearest analogy that I can think of. I think about how the spleen works. It's pretty much like the containment unit in Ghostbusters. And if it breaks, then everything gets loose in the body, and you've got sepsis for miles. Anyway, moving on. For your genital system, we'll talk about the males first. Um, the abdominal space also holds your reproductive organs. For the males, we have the testicles, the epididymis, vasa deferentia, seminal vesicles, prostate gland. You have your penis. For the females, you have ovaries, you have your fallopian tubes, uterus, cervix, and vagina. A lot of the same tissues make it up for both sexes. So your testes and your ovaries are pretty much the same. A lot of that is just, the way that it grows is determined by our gender, but the tissues are the same. Your urinary system controls discharge of certain waste materials from that's being filtered from the blood. So this is your liquid waste, and these are also your electrolytes. Like if you get too much potassium, because we can't store potassium, so the only way to get it is to eat it. The only way to get rid of it is to discharge it. And if it gets too high, we start to run into some major problems. The kidneys are solid organs, and think about that too. So they don't have a lot of nerve endings, not at least not that register pain. So if you have a problem with the pain, let's say you have nephritis, your kidneys, you're not going to be able to just say it hurts right there and point right to your kidney. This is going to be diffuse pain that kind of spreads around. It's going to spread around to your back a little bit, so it's called pain in the flanks. Um, a lot of times that's your kidneys that are doing that. If your patient can't really pinpoint it, and they say it hurts kind of around the side and to their backside, it's probably their kidneys. And it can be, doesn't necessarily mean the kidneys are failing, but it could be that one of them is swollen. Um, just, something going on. It could be a sign of an infection. Your ureter, your bladder, and your urethra are hollow organs. You do have two kidneys, one on each side of the body, and the way that they feel is they're kind of like O2 sensors in a vehicle. They do their job, but they lose a little bit of themselves as they do it. So as we get older, our kidneys are constantly losing kidney function. If you're 60 years old, your kidneys are probably not functioning at 100%. You may only be functioning at like 10%, 15%. And sometimes, and that's usually fine. Like it doesn't take much, but when the kidney really does fail, then we wind up with our patients on dialysis because they need help filtering the body. These are in your right and left upper quadrants, not your lower quadrants, but they're posterior. They're toward the back. That's why the pain kind of radiates to the back side. So again, they regulate acidity and blood pressure, mainly by fluid therapy. So if as a paramedic, if they want to up somebody's blood pressure, they're going to give them fluid. So by that mindset, if the body wants to lower blood pressure, they're going to release fluid, and that's how the kidneys do that. The kidneys also tell you when you're thirsty. When the kidneys are trying to process things and they don't realize, or I'm sorry, they don't realize when they can't filter properly because there's not enough fluid in the system, your kidneys release a hormone that tells your brain, "Hey, idiot, get something to drink." So that's another interesting thing about them. Your blood flow is very high in the kidneys because it's a solid organ. You have two ureters, one running from each kidney. They connect at the bladder. Your bladder is basically a water balloon. All right. We never fully empty our bladder unless we have a catheter in it, and we never really fill it all the way either. Usually, the body will just make you release it. That way, you don't risk popping your bladder. The bladder empties to the outside of the body through the urethra. For males, the urethra passes from the anterior base of the bladder through the penis. For females, it just ends at the front of the vagina. Normal adults, about 1.5 liters to 2 liters of urine a day. You guys in the field, not necessarily needing to know that, but if you take your EMT and you decide to go be an ER tech and you start having to monitor patients' input output, then that's something you may want to know. And they'll teach you that. I mean, not teach you, you learned it here, but they'll remind you. The nurses will tell you, you'll start to learn that kind of stuff. So for anybody that's not seen the male urinary system, there you go. All right, for your pathophysiology, these are the things that can go wrong. The abdominal cavity is lined by a membrane called the peritoneum. This is what also covers your organs. The parietal peritoneum lines the wall of the abdominal cavity itself, and it's going to be very, 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 very vascular. And it's also going to be a lot of nerve endings are going to be running through there. So if this is your problem, your patient will say it hurts right there, and it's, there is no confusion over where the source of the pain is. They will point right to it. All right, the presence of foreign material like blood, pus, bile, pancreatic juice, amniotic fluid can irritate the peritoneum, causing peritonitis. So if there's a problem and you've got some internal bleeding that can cause it, and this is going to be painful, right? Amniotic fluid can get in there if there's a breached birth, or like an ectopic pregnancy or something where they don't catch it for whatever reason, or even if it's a normal birth and something punctures and it just gets loose into the abdomen, that can cause some issues. But anything that's not supposed to be there will irritate this. Acute abdomen, that's our medical fancy term for basically saying that somebody has a sudden onset of abdominal pain, right? We talk about, there's two words, acute and chronic. Acute being short and just kind of starting, chronic being something long-term, something you live with. So acute abdomen is the sudden onset of abdominal pain. It's usually associated with severe progressive problems. If it doesn't get treated, it's going to get worse. Peritonitis, anybody want to take a stab at what that means? Yes, it is on the slide. All right, so I guess because of that, we'll just move on. Anything itis, remember, anything itis is inflammation, and then perito would be the peritoneum. It's typically causes ileus. Ileus is paralysis of the muscular contractions that normally propel material through the intestine. So that peristalsis that we have that's supposed to happen, if we have peritonitis, it actually hinders that ability to happen. So now you run into the problem of things getting backed up in your intestines. The retained gas and feces can cause abdominal distension. And depending on where this is blocked at, we can get some major problems, right? If it's up close to the stomach, then the stomach's it won't be able to push anything through any further. It's kind of like things are just getting backed up. So if the stomach can't move it forward, it's going to put it back out the way it came, which is through vomiting. And you will feel nausea with that. Like that's going to be, think of this like food poisoning. As it's moving through you in the beginning, when it's still up high in the abdominal tract, you're going to throw it all up. As it passes through you, then it's going to turn, you're going to start to have a mix of vomit and diarrhea, and then it's going to end with diarrhea, and then you're going to be fine. Peritonitis is frequently associated with nausea and vomiting, like I said, and it is also associated with loss of bodily fluid into the abdominal cavity. So with that being said, what's something we need to be concerned about with our patients if they're losing fluid into the abdominal cavity? Not to mention they're throwing up and they probably have diarrhea. Dehydration, there you go. Yes, and this is actually worse in kids, right? Because as adults, when we get thirsty, we drink. We don't really care if we're going to throw it up. We just drink if we need it. Kids, though, when they're experiencing nausea and vomiting, they tend to just say, you know what, I don't want to put anything in my stomach anymore, and they'll stop drinking. So they're losing all that fluid, but they're not replacing it with anything. And sometimes parents don't realize that, they don't think about that, and so their kids wind up dehydrating. And the reason why they're having to call 911 has nothing to do with the fact that they're having problems with their digestion for food poisoning or something of that sort. It's just that their kids are really dehydrated because they stopped drinking. All right. Your patient, when you have this, they may present with tachycardia and hypotension. So look for signs of shock. Diverticulitis. This is an inflammation in small pockets, weak areas in the muscle wall. So we were talking about the aortic aneurysms earlier. If you were to take that same concept and apply it to your small intestines, that is diverticulitis. Um, it's just weak areas in the muscle walls, and they start to inflame. There's no real pressure, not like the aorta. There's no real pressure. So those weak areas, they tend to not. They just don't move the wall that well or move the food that well, and so you run into issues where little toxins start to build up, and it irritates that area. That's diverticulitis. They may experience a fever because the body is seeing this as an infection. All right, so they may just have that. Um, cholecystitis. This is an inflammation of your gallbladder. Again, same thing. Anytime you have an inflammation, it's usually because the body, at least unless the body caused it, because sometimes we inflame because our body wants to. But for something on the outside causing it like that, it's going to create a fever because again, the body's going to see it as a possible infection. Acute appendicitis. This is the big one that a lot of times we want to try to catch in the field. The patient's temperature may be within normal limits. The body's not going to see this as an infection. However, the pain will be very, very severe. When you're doing your abdominal inspection, you're going to find that when you press on their right lower quadrant, they actually start to feel a little better. But when you move your hands off of it, it comes back with a vengeance. That's called rebound tenderness, and that's a major sign that they have appendicitis. Something that one of my old paramedic partners used to do, he would tap the bottom of their right foot, and if they felt pain in their abdomen from that, then it's pretty much the same thing. It told them that they had appendicitis, which I actually like that better because it's less pain, but it's still enough to tell you what you need to know without hurting your patient more. All right. For abdominal pain, we have two different types of nerves that supply the peritoneum. You have your abdominal pain can have different qualities. So your parietal peritoneum is supplied by the same nerves that supply the skin of the abdomen. These can perceive pain. They actually have pain receptors here. That's why I was saying, like, depending on what your patient describes their pain as or how they describe it, this can tell you pretty much where they're having the problem. The peritoneum, the musculature of the abs, all that stuff has a lot of nerve endings that can register pain. So it's going to be more exact. It's not necessarily more severe. It's just not spread out. The visceral peritoneum around the organs is supplied by their autonomic nervous system. The nerves are far less able to localize sensation. So when that's the problem, the pain sensations are going to come from further away. They're going to come from the nearest pain receptor, which may be halfway around on the other side of the organ or something. Nerves are far less able to localize that, obviously, and patients will not be able to describe exactly where the pain is. This is called referred pain. So we talked about cardiology the other night. If your heart is ischemic and it's hurting for whatever reason, there's not a lot of nerve endings there. So your heart, if the heart muscle is what's hurting, it's not going to be, oh, it hurts right here. It's going to be, oh, it hurts all over, and because my heart points to the left, I'm going to feel pain going down my left shoulder a little bit because those nerve endings are picking up the problem. Ulcers. All right, so this kind of goes back to what we were talking about with the medication earlier. An ulcer is basically a sore in the stomach. Or a sore anywhere. If you've gotten them on your like your gum line or your inner lips or whatever, they're the same thing. Earlier we said that the stomach is full of hydrochloric acid. It's the strongest acid on the planet. So what's to stop it from just eating us? right? How are we able to survive with the strongest acid on the planet just chilling and churning in our stomachs all the time? And if you've ever had heartburn, you know that stuff really does burn. But how do we survive that? Yep, good. Yeah, it kind of says it in the slide too, protective layer of mucus erodes, but it really is. It's just a very strong alkali um, mucus wall that counteracts that stomach acid. Um, Normally, the stomach acid can't get past that wall, but if for whatever reason something you eat or a medication you take, like an NSAID, if you notice, all your NSAIDs usually even ibuprofen says take with food. Um, and that's the reason why, is because if you don't, and there's no buffer between the ibuprofen and your stomach lining, what it winds up doing. Actually, let me back that up because I can explain this better. The reason we take an NSAID is because we're trying to fight an inflammation, right? So somebody with arthritis is taking a leave to fight the inflammation in their knuckles. I do that at 37, go figure. But the NSAIDs that we take are designed to hinder a certain chemical that stimulates inflammation. Because, like I said, sometimes the body wants to do it. There are reasons we'll learn about when we get like the burns, for example. We'll learn about that. But that medication, it stops that production. Well, the problem is that production is also what builds I'm sorry. It also is what's in the stomach. It's the same stuff. So if you take ibuprofen, for example, or another NSAID, say like aspirin, um, and you don't eat it with food, something to kind of water it down while it's in your stomach or buffer it out, that medication will take a little bit of the stomach lining with it. And if you take enough of it, or you take it for long enough, eventually um, that mucus lining is going to get so thin that the stomach acid is now able to start to burn at the stomach itself, which can lead to the ulcer. Um, if you have And there's different types of ulcers. You have ulcerative colitis, which we'll get to. I think that's in here. It may not be, but depending on wherever that injury is, that is your ulcer. All right, for gallstones, the gallbladder is a storage pouch for digestive juices and waste from the liver. Gallstones may form, and if the blockage does not pass, it can lead to severe inflammation of the gallbladder called cholecystitis. Now, gallstones happen. All right. I remember I was looking at an X-ray of an elderly woman at Keesler back when I was still training to be a medic, and she had at least a dozen gallstones in her gallbladder. If as long as they're chilling there and they're not blocking anything, it's really not a big deal. The doc was looking at it. I saw it and I was like, holy crap, are y'all gonna have to go cut her open to get these out? And he said, no, if they don't move, they're not a problem. So he was like, I don't really care. Whatever, we'll send her home. She'll be fine. Um, so the presence of gallstones is not the issue. It's when they block one of the canals. That's when it becomes a problem. Condition in which the wall of the gallbladder is inflamed, which is your cholecystitis. One of the problems that you'll see, sometimes your gallbladder can rupture if the gallstones get too big. That's a big problem. Or if they block it off and no liquids can get through, it can pop it. If this is what you see, like if your patient has gallstones or cholecystitis, the pain is constant and it's going to be severe. It's going to be a 10 out of 10. They'll be screaming, and it'll be in the right upper. So appendix is where? Which quadrant? Whew. Yeah, see, there you go. 166 stones. There you go. Right lower. Appendix is in the right lower. Your gallbladder is in the right upper. So right-sided abdominal pain is going to be some bad juju. We really don't like things, well, we don't like things hurting on any quadrant because usually it means it's an organ. But the right side, if it's upper, it's your gallbladder. And as you can see, that's not fun. If it's lower, it's your appendix. Both of those could kill you if they rupture. All right, pancreatitis. This is an inflammation of your pancreas. It's caused by obstructing gallstone, alcohol abuse, or other diseases. Some of your signs and symptoms, you have pain in the upper left and right quadrants because this organ actually resembles in shape. It looks like a miniature liver, and it goes across both your upper left and upper right. A lot of times this will radiate to your back because of where it sits. It sits a little bit deeper, closer to your spine. Your patient may report that the pain is worse after eating. That's going to be something you may see. They're going to have nausea, vomiting, abdominal distension, and tenderness. And if it actually bursts, then now you're going to have sepsis issues and hemorrhage may occur. Even though it's a hollow organ, you could still have a lot of blood loss. All right, appendicitis. We talked about this a little bit earlier. This is an inflammation or an infection in the appendix. Doesn't necessarily mean that it's burst, just swollen and at risk. This can cause tissues to die, causing an abscess, peritonitis, shock. This one is not something that we really like seeing happen. Usually the first sign of a bad appendix, they're going to take it out just to be safe. Pain is initially more generalized, again, because it's an organ. So it'll be dull, but not dull like it doesn't hurt bad, dull like they can't pinpoint it. It'll still be excruciating and radiating out and all that stuff. They may feel this kind of in the middle, but usually when you're palpating, you're going to get most of your information from the right lower. Some signs and symptoms: nausea and vomiting, anorexia, which means what? I know we have a stigma of the term anorexic because we all get the same thought, but what does anorexia actually mean as a medical term? It's not throwing it up. That is actually bulimia, is throwing up all your food. Word starts with an A. Think about that. All right, so it's without. This is a tough one. So it's, yeah, there you go. Good job. Loss of appetite. Anorexia is they just don't eat, and it's not necessarily by choice. Somebody that's anorexic, that's actually a disease, um, or a symptom, depending on what you want to apply it to. Because if they have an inflammation of the appendix, anorexia is not necessarily a disease in itself; it's a symptom. But they're going to stop eating. They're not that urge to eat, that hunger is just not going to be there. Fever and chills, they'll have that. The rebound tenderness, like I was talking about. So when you get to your head to toe and you're pressing on the abdomen, you get to the right lower. When you press on it, they might either they're not going to feel any worse, at least. Usually they feel a little bit better, but when you come off of it, that they're going to scream bloody murder because the rebound tenderness. Gastrointestinal hemorrhage. This is bleeding within the gastrointestinal tract, and it can be anywhere in there. This can be at the top, close to the stomach, in which case, as the blood passes through your system, it's going to be digested, or it may be closer to the anus, which means that you're going to see bright red blood. I want to say this: if you get called out 911 to somebody that's having some abdominal issues, and the you see bloody stool, depending on what the blood looks like, can kind of tell you where they may be having the problem. If the blood is bright red, that means that they're bleeding fairly close to their anus. It's not necessarily bleeding, from the anus. It could be somewhere on the descending colon, or anywhere up in there. That's usually an issue that a doctor can go in with a scope and figure out what's going on. If the blood looks like coffee grounds, like it's all browned out and dry and everything, then that means it's been digested. So that blood got into the GI tract a lot further up, closer to the stomach. Yeah, if it's bright red, it could be hemorrhoids. But like I said, I mean that's and because those can be internal or external, which I think we may actually mention those in this class. We'll see. But yeah, any blood in the stool can come from anywhere from the esophagus on down. I mean, it just depends. And then, however far from the anus it goes, that's just that much more digestion is going to happen to it along the way. This can be acute or chronic. So remember the difference in those terms. Acute means short term, chronic is long term. Esophagitis, swelling of your esophagus. This occurs when the lining of the esophagus becomes inflamed by infection or acids from the stomach. If somebody has GERD and they're dealing with heartburn a lot, they're gonna deal with that. It can also lead to a couple other things. So, like you'll see, let's see, actually, does it mention? Okay, we're gonna get to that. So I won't go there yet. But anyway, GERD will cause esophagitis, just that constant burning, constant acid touching it. Because remember, your esophagus doesn't have that protection, not like your stomach does. Usually, that gastroesophageal valve is supposed to seal, and the stomach acid doesn't come up. But if you eat spicy foods, if you had a pyloric stenosis and the damage that came from that as a baby, any number of things can cause that valve to not want to work right, and then acid's going to come up. If you get a patient talking about chest pain, one of your questions, I'll mention it here, one of your questions can be, does it feel better or worse when you change positions? Like, for example, if they lay down, does it get worse? If they sit up, does it get better? If it's positional, most likely what you're dealing with is heartburn. Um, so you run in some of your bigger issues with that is, esophagitis. You're gonna look at that, esophageal varices, which you're gonna talk about in a second. Um, that's what you're looking at. If it doesn't get any better, or if it stays the same regardless, then yeah, you're probably looking at something with the organ. Doesn't necessarily mean a heart attack, but you can start to aim down the cardiac route if you have that information. All right, so let's talk about GERD for a quick second. This is gastroesophageal reflux disease, just basically acid reflux. Tums work fantastic for it. So I'm not telling you to give an unauthorized medication to your patient, but if you're thinking heartburn and they've got some, ask them to take a Tums. And if it makes them feel better, then fantastic. This is a condition in which the sphincter between the esophagus and the stomach opens, allowing stomach acid to move up and into the esophagus. And since we've been open about medical issues, I will share one of mine with you. I actually had, as a baby, I had what was called a pyloric stenosis. Basically, it's not something you're born with. You develop it a couple days later, and it's dangerous because it usually doesn't develop until you're out of the hospital and at home. The pyloric valve is at the bottom of the stomach. It leads into the small intestines, and stenosis means it basically locks up. So that valve stopped working, which meant that whatever I ate and drank could not get into my small intestines. It would get forced back out of my stomach the only way it could go, which was back out the mouth, projectile vomit across the room. Now, my dad was a salesman, and my mom was she was recreational with a couple of things at that age. Um, so they didn't have a clue what was going on. And they didn't think about the fact that I was going to dehydrate because I couldn't keep anything down. So it took them a little bit, plus the fact they didn't have health insurance. It took them a little while to call 911. When they did, I actually went to cardiac arrest in the back of the ambulance, and they got me back, thankfully. But when I got to the hospital, they had to actually go in and cut that valve open. But by then, the damage had been done. The top valve of my stomach, the gastroesophageal valve, no longer functioned like it was supposed to. So now it doesn't close all the way. Didn't really think about that growing up. When I was in sixth grade, my dad had remarried, and my stepmom was a nurse. And we'd be sitting there watching TV after dinner, and almost every night she'd see me sitting there on the couch, kind of yawning, taking big breaths, almost like I just ran around the yard for a second. And then like she'd see me fidgeting and trying to sit up and all that stuff. And I'm like I said, I'd done it my whole life, so I didn't think anything of it. Turns out that's what I had was that pyloric stenosis had caused that valve to not work right, which gave me GERD. Um, and then that led on to Barrett's esophagus and all that stuff. So it's not fun. And if it's bad enough, GERD can actually aspirate. You'll get that burning sensation all the way down in your airway, all pretty high up in your esophagus. I've coughed up stomach acid before. I've coughed up blood before. Um, it's controlled with medications, but because I'm not the only one out there that has had it since they were a baby. So there are people that are gonna go there in their most of their life without ever giving it a second thought. And then by the time it gets bad enough for them to call 911, it's because it has progressed to that point. And now they're like, holy crap, I don't know why I just coughed up blood. Esophageal varices. This occurs when the amount of pressure within the blood vessels surrounding the esophagus increases. When the blood flow is blocked in the portal vessels dilate, causing the capillary network of the esophagus to begin leaking. Like I said, remember your vessels that are around your digestive tract are called the portal network. They all connect through with the liver, and that's how you filter stuff out. So if the portal circulation gets clogged, you're going to see it sometimes around the vessels in the esophagus. You don't see that. Obviously, there's no way for you to look at that, but that's what that is. If the pressure continues to build, if the problem gets worse, the vessel walls may fail, causing a massive upper gastrointestinal bleeding and hematemesis, or however, I can never say that word. But basically, they're going to start to bleed into the esophagus directly from the vessels, and then they're going to start coughing up blood. Mallory-Weiss syndrome. This is where the junction between the esophagus and the stomach tears. I have not actually encountered this, thankfully. It sounds pretty painful, and it's a major problem because if it tears or disconnects, every time you swallow, you're getting solid food in your thoracic cavity. You're going to have a piece of steak hanging out between the heart and the lungs, or wherever. Depends on where the rip is and how bad it is. This can cause severe bleeding and possibly death. Some primary risk factors for this are alcoholism and eating disorders. Bulimia can cause this, basically. Prevalent in older adults and older children. Vomiting is a principal symptom. In extreme cases, patients may experience signs and symptoms of shock, upper abdominal pain, hematemesis, sounds right, and melena. Gastroenteritis. This is an infection combined with diarrhea, nausea, and vomiting. Usually caused by bacterial or viral organs, and this is what we classically just call this food poisoning, gastroenteritis. It enters the body through contaminated food or water. This can also be caused by non-infectious conditions such as an adverse medical reaction, toxic exposure, and sometimes chemo will do this as well. I know that we had a lady that worked with us that was on chemo, and she would always have problems with digestive tract, keeping things down, or not having diarrhea and stuff like that. And it was actually the chemotherapy that was doing it to her. Diverticulitis is the next one up. This was first recognized around 1900 when the amount of processed foods eaten increased. The consistency of stools became more solid, requiring more intestinal contractions, which increased pressure on the colon. So basically, bulges in the colonic walls result from increased intestinal contractions, and fecal matter is caught in the bulges. It kind of gets stuck there. The bacteria gathers there, and then with that comes the inflammation and then the infection. And if it gets bad enough, it never gets treated, it's gonna go down to sepsis. So we worry about shock in a lot of different ways. This is one of the reasons why I didn't want to go just cover shock all at once and then not touch it again. It's because shock isn't just blood loss, right? There's different types, and one of the biggest forms of shock that we worry about with GI problems is sepsis. All right. Next on the slide is hemorrhoids. This is created by swelling and inflammation of blood vessels surrounding the rectum. They can be internal or external. Does it say that? Okay. Basically, they are sacs that line your intestine, or not your intestine, sorry, line your rectum. And if you have a problem with, say, constipation, and you push or you routinely rupture those areas, not chafe them up, but actually like cause those blood vessels to break. Those blood vessels are going to pour into those sacs. And now basically you have water balloons hanging out around your rectum. They can be internal or external. If it happens and they stay internal, it's not that big of a problem because they'll eventually they'll drain out. The lymphatic system will take care of it, and then you go back to normal. Where they become problems is when they become external. So if you create one of these water balloons and it gets stuck on the outside of your rectum, um, that blood can't get out. You've basically pinched off the water balloon. Now the body can't do anything with it. That blood will, if it ruptures while it's still liquid, um, it'll be bright red, obviously because it's arterials that are doing this. But if it's full of liquid, then obviously you're going to have a lot of blood loss. If it's not, if it's been in there for a while, it can cause a clot. Now it's not normally a clot that's going to get tossed around in your bloodstream because again, this blood is out of your system at that point or out of your vasculature. But once it clots, it's really hard to get those hemorrhoids put back where they go, like back internal. So a lot of times they're going to wind up needing to go to the doctor for surgery. If you come across somebody with that, they don't have to go with you because it's not necessarily an emergency, but they do need to schedule an appointment to have that taken care of. And a surgeon will go in, cut the clot out, patch them up, and they'll sit on a round pillow for a couple of days, and then they'll be good. All right, for your urinary system, cystitis. This is a bladder inflammation. It's common, especially in women. Also called urinary tract infection, which is what we always call these. They are much more common in women. That doesn't mean men get them, or men. I'm sorry, it doesn't mean men don't get them. It's just that the opening to the urethra on a female is much closer to the body than a male's. Our urethra is longer, so it's a little bit harder for infections to take hold in us than it is for women. But it's usually well, not usually. Sorry, I'm getting stuttered up on my words. This is always caused by a bacterial infection, and it can become serious if it infects the kidneys. One of the things that you're going to see in your patient if they have an unchecked UTI or they haven't gone to the doctor, haven't gotten any medication for it, is you're actually going to see it start to affect their mental acuity, their alertness. They may be out of their head, kind of like they're drunk or whatever, and it winds up being that it's a UTI that has managed to get loose in their system. Um, Reports of urgency and frequency of urination. So they may have to go to the bathroom more often. Basically, the bladder is going to feel like it needs to empty itself more often, even though it's not necessarily fuller. But sometimes it may be. If your body recognizes the infection that is actually there, it may try to flush it. So they're going to urinate more. And if they don't drink, we run into the dehydration problem again. So again, that's something else we need to think about is when you're talking to your patient, ask them like, how often are you going to the bathroom? If they tell you, or if they just offer that up, like, hey, I keep having to go to the bathroom. Ask them if they're drinking enough to compensate for that. Like I said, adults usually do. Kids tend not to. Your kidneys play a major role in maintaining homeostasis. Actually, hold on a second. Yeah, let's take a break. We'll take a 10-minute. We got about 20 slides left. So we'll be back at 7:30 and then we'll finish out. All right. Let's go ahead and get this show back on the road. We got a little bit more to cover, and then we'll be done. So let's talk about the kidneys. Your kidneys are your big filter, like I was saying, especially for anything blood related, anything that might be in your bloodstream. They play a major role in maintaining homeostasis because they filter out things and keep certain electrolyte levels in place, like potassium. That's a big thing. If we have too much calcium, we just store it in our bones or something. If we have too much sodium, you pee it out. It's no big deal. Or you can have some high sodium levels, but we don't want to get rid of, or we don't want that to build up too much either. So your kidneys actually filter out those issues. When the kidneys fail, uremia results, which means there's too much urea in the blood. All right. Kidney stones can grow over time and cause a blockage, which is a problem, obviously. And we do pass these. Sometimes we'll pass them just like any other. And if you've ever passed a kidney stone, you know it. Basically, kidney stones are crystallized chemicals in the urine. They solidify. The blockage can lead to swelling. The pain is caused by the stone moving within the ureter. It's a very sharp, jagged piece of rock, and it will poke, prod, tear, slice all the way through. It's extremely painful. Yeah, no, they're bad. And the problem too is even though if anybody's ever you get those and you like once it's passed, you get that relief of, oh God, it's finally done. Not always, because depending on the damage that it does, you're gonna hurt every time you go to the bathroom until it heals up. So keep that in mind. Your patient they may have passed a kidney stone, first one ever, 3 or 4 days ago, and they're still hurting, and they're calling you not because it's the worst it's ever been. They're calling you because they're worried that it's still hurting. Um, the stone may pass on its own. If it gets too big, it has to be surgically removed. And also, if like I said, your kidneys do start to wind down over time. Um, but if it's a stone that blocks things, it can cause problems like right then and there until the stone moves. Just like a clot going to the brain and causing a stroke, kind of the same thing here. So acute kidney failure is one of these examples, or that would be an example of acute kidney failure. This is a sudden decrease in function where your kidneys go from working like 60% capacity to nothing. This occurs from hemorrhage, dehydration, trauma, shock, sepsis, heart failure. All these on the slide? No, no. Okay. Drug abuse and kidney stones. Kidney stones being at the end because it's usually not the way that it causes that, but it is possible. Reversible with the prompt diagnosis and treatment. Usually, it's going to wind up being fixed in the hospital. We can't fix that in the field. Chronic kidney failure is something that we typically see a lot more often because it's over time. Eventually, your kidneys will start to wear out. That's irreversible. Once they get to that point, they're not going to rebound. They don't regenerate. It's progressive. It'll develop over months or years, so that you're just going to start to notice that it gets harder to go to the bathroom. Or if you're like those of us that are in the fire service, depending on if your department follows these guidelines or not with the NFPA, we're supposed to get a health assessment every year, a firefighter physical, and with that comes blood work, and that's when they're going to start to tell you, oh, your cholesterol is high, and oh, so is your potassium and your sodium, and that usually means your kidneys are messing up. So then they kind of go down that route and try to figure out what's going on. This is often caused by diabetes and hypertension, these chronic issues. Kidney tissue shrinks and function diminishes as we age. It's just as they start to wear out, it happens. Eventually, dialysis or a transplant is required to remove waste from the bloodstream. Some symptoms involve altered level of consciousness, seizure, coma, lethargy. What is lethargy? I need to get you all on the right slide. That wasn't the right slide. Okay. Anybody tell me what lethargy is? Well, I mean, that's one way to look at it, is lazy. Lethargy is tired. So they're run down. They're having a hard time staying awake. They move slow. They get kind of like dreary, drowery, whatever, sluggish. That's a good word for it. You can also have nausea again because basically there's a problem with the route at this point. Headaches, cramps, and edema in the extremities in the face. The reason being is because not only are your kilties filtering out your potassium and your sodium and everything, but they're also filtering out fluid that you don't need. Excess fluid that's where it comes from to make your urine. If the kidneys aren't working, then the fluid's not going to pass through them, and you're not going to go to the bathroom anymore. So, what happens after eating at the Air Force mess hall? No, that's called a food coma because the food's really good, and you know you loved it. But anyway, with the fluid not being able to get out of the body, it's going to start to just kind of build up. So you'll get that edema. It stays in your bloodstream, and all that fluid just starts to seep out, and you're going to see it in your extremities. We hating on Air Force food. You're just jealous that you didn't get lobsters at your bases. I understand. I got you. All right, female reproductive organs. Gynecologic problems are a common cause of acute abdominal pain. Lower quadrant pain may relate to the ovaries, fallopian tubes, or the uterus, and we're going to really get into this when we start talking about childbirth and OB. It's not a fun chapter, but it is very interesting because there's so many things that can kind of go wrong. It's like there's a very good reason why there's a whole medical route that you can go down this road. So we're going to cover that in chapter 23 when we get to gynecologic emergencies. We're not really going to go too much into it here. Just know that if there's a problem, if you go to an abdominal pain and it's say like a 17, 18-year-old girl or whatever, and she's having pain across her lower tube, it's probably going to be something to do with her organs. And it can be anybody. It can be postmenopause women. It can be anybody, any age. Other organ systems. So we talked about the aorta. It's not just the hump at the top of the heart, right? It runs all the way down past your abdomen or past your belly button, and then it becomes your femoral arteries. So here we are again with the aortic aneurysm. Weak areas can result in the abdominal aortic aneurysm. These are difficult to detect. So you were right when you asked about that earlier. It seems hard for you to figure out in the field. It really is. Use extreme caution when trying to assess or detect at AAA. We really don't want to poke and prod too much, but if you do press on the abdomen and you feel like a pulsating mass that's kind of in time with their pulse, you may be on their actual aneurysm spot, so be careful with that. Development of an aneurysm is slow. That shearing has to happen for a while before it gets to the point where the aneurysm actually grows. If the aneurysm tears or ruptures, massive hemorrhage may occur, and massive is a massive understatement. Again, that is like you barely have time to register what happened, and your patient's going to be dead. The pain may be described as a tearing sensation. Like I said, that's specific to that. So handle the patient gently during assessment and transport, and if at all possible, get a helicopter out there. That's their best bet. Not only does it get them to a hospital faster, but it also takes away the bumps in the road and all the things that could exacerbate that aneurysm. We really don't want it to pop. If you have to take them by box, that's fine, but I wouldn't make that your number one choice. Pneumonia, especially in the lower lungs, can cause ileus and abdominal pain. All right, a hernia. Are these on? No, hernia's next slide. There we go. A hernia is a protrusion of an organ or tissue through a hole or opening into a body cavity where it doesn't belong. So, for example, your esophagus is about 9 inches long. It runs down between your lungs to your diaphragm. And it goes through a hole in the diaphragm, and your stomach is posterior to that, right? So the stomach is not in your chest where your heart and lungs are. But to get your esophagus to the stomach, you have to go through a hole in the esophagus to get there. If for whatever reason the stomach protrudes up through that hole and then kind of encroaches into the chest cavity, that is a hernia. There's a couple other places in the body where that can happen. We have hiatal hernias, but it's all basically the same thing. Hernia, that's just what it means. It's a medical term. It may not always produce noticeable mass or lumps, depending. You may not see it. There was actually a patient that I covered at the hospital that had a hernia. It was almost like he was eviscerated. Like it was a massive, massive hernia in his abdominal wall. And most of his intestines and everything, I don't know what caused the hole or what. It was not a break in his skin, but all of his stuff, he looked pregnant because all of his organs had pushed past his abdominal wall and they were stuck between the abdomen and the skin. It was really, really weird to see. That was a surgery. There was nothing we could do except supportive care, even in the hospital while he was in the ER. Like, what do we do with this? But those are hernias. Like I said, they can be different places. A surgical wound that fails to heal properly can cause this. So C-sections sometimes may herniate if they don't heal properly. It can also be just a natural weakness in an area like your groin. So people that work out a lot, if they lift heavy, they can herniate. Hernias, well, I already said that. Let's see. Strangulation is a serious medical emergency. Okay. Yeah. Strangulation of an incarcerated hernia is what that's talking about. So this is where blood supply is compromised because the hole that it went through is pinching it off. If an organ herniates and that hole that it shot through is now pinching off half of it, blood supply can't get to half the organ can fail, and now you've got real issues. So serious hernia signs and symptoms: a formerly reducible mass that is no longer reducible, pain at the hernia site, tenderness when the hernia is palpated, and red or blue skin discoloration over the hernia. If you see that, that usually means that blood is pooling up around it at the same time. So you've got internal bleeding on top of it. All right, for your patient assessment, beating the dead horse here, BSI scene safety is first, right? So when we start our evaluations in the boot camp, which your boot camp's not your evaluation, but you're going to be doing all your hands-on, that needs to be the first words out of your mouth on every scenario that you do. The only exception to that is if you walk in the room and you put gloves on. If I see you actually go through the motions of it, then I'm not going to make you say the word. In fact, I would rather see you go through the motions of it because you're not going to walk up to a real patient and go BSI scene safety. Put some gloves on. We'll have them there. Y'all wear the gloves. Ensure your scene safety. Follow your standard precautions again. Consider donning a gown, especially if you're having a patient that is vomiting or has any real chance of spewing any fluids on you. Sometimes these situations are the ones where you really want to treat it like a hazmat scene because they can get pretty bad. Determine your number of patients and consider the need for additional or specialized medical resources. Request them early, mainly on the ones that are going to be life threats. If it's food poisoning, there's really not a lot that anybody else can help you with. But if it's an aneurysm, like I said, consider getting the helicopter out there and make that decision fast because you're already at the scene at this point. Time's not on your side. And even if it's not going to rupture in the next 30 seconds, you don't want somebody to just sit there and continue to go untreated when they should be heading to the hospital. So get the helicopter en route as quick as you can. You can always turn them away if you decide you don't need them. Consider your mechanism of injury, your nature of illness. All right, acute abdomen can be the result of violence. So keep an eye out for, blunt trauma, penetrating trauma like stab wounds, gunshot wounds. Be vigilant. If you inspect your patient and that's what you find knife wounds and gun wounds, going back to your scene safety, the first question that should pop into your head is, where's the person that did this to you? Because they may come back. So there's an additional resource right there. It should scream in your head, get law enforcement on the scene. All right, and then again, we'll talk about the actual traumatic injuries to the abdomen when we get to the trauma module. For your primary assessment, go through your ABCs. Again, we are beating the dead horse here, but it's mainly because when you get to a scene that is just really gnarly, straight out of a horror movie, and you don't really know what to do, you're like, holy crap, what's going on here? This is the framework that you can fall on. Like, all right, I don't know what this is, and this is pretty gnarly, but BSIC and safety, and here we go. So get to your primary assessment. At this point, you're actually touching your patient. ABCs, rapidly observe your patient in the environment. The patient will often have knees drawn up to ease the pain of an abdomen. If you're hurting in your abdomen area, the position of comfort is typically the fetal position. All right, or we call it guarding. You may have heard medical, like EMTs or doctors, call it guarding. It's where they cross their arms in front of their abdomen, like, no, I don't want you to touch it. That's almost a automatic response. That's not them they're not being assholes to you. They're hurting. And so, like, if that's a sign that they're being honest when they say it's a 10 out of 10. If they're curled up in the fetal position and the guarding like that, where they don't want you to touch them, if there's ever any doubt in your mind about whether somebody's faking or not, that's a sign that they're not faking. Some of the issues you're going to see with your primary, what do you think? Let's see, I don't want before I ask it. Okay, well, it does say it. So I'll read it. Abdominal pain can cause shallow, inadequate respirations. And so my question to you will be, why? Why if they have extreme stomach pain, it doesn't even matter what it is, we'll just say the pain. Exactly, right? It hurts. Anybody with bad stomach pain in your own history, you think about that? Think about the worst stomach pain you've ever had. If you've ever had something like appendicitis or a real emergency and that level of pain, you really don't want to take deep breaths. It hurts. It hurts to get more than any real, like a half a breath. So you're going to be struggling to maintain your patient's minute volume with these. They may be breathing, but they're not going to be breathing well if the pain's real bad. For circulation, ask the patient about blood and vomit or black tarry stools, because that's going to be basically your blood loss. It's going to be, did they throw it up or did they poop it out? All right. If they say no, they haven't done any of that, then they probably still have all their blood in their system, unless there's some weird injury that's bleeding out or whatever. But usually that's traumatic. There's very few medically caused holes in the vascular system. And like I said, the one that we learned about, the one that comes to mind, if that happened, they're not going to be alive talking to you anymore. So that is usually, if they're alert, they may have an aneurysm, but it hasn't ruptured. Check pulses in both arms. And if you're worried about the pain, or if you're worried about an aneurysm in their abdomen, then do like I forget what you said, it was your sister or your wife or cousin or somebody, do like they said, check the pedal pulses. Because the problem is kind of like a spinal problem. It's everywhere below the problem. So if the aneurysm is around your belly button, then checking the pulse in both arms, you're still going to get the same pulse. The problem's not that far up. Make your transport decision. If it looks like an emergency to you, if it doesn't look like they're just being a baby or faking it, which is pretty rare to somebody, because if somebody's going to call 911 and they're not serious, they typically don't go down the GI route. So if there's signs that something is wrong, like you do the checks for appendicitis and they come back, it's positive, like they're all right, tap their foot and their stomach hurts from it, they're going to be a high priority. Get your sample history and get your OPQRST with this one as well, because remember, this is pain, right? They're complaining of pain, so we want to know more about that pain. Some things that you want to figure out or look for in your sample, or what's on this slide. So ask them about nausea and vomiting, change in bowel habits, urination if they've had either more or less than usual, weight loss, belching or flatulence, pain, other signs or symptoms, and concurrent chest pain. For your secondary assessment, this is your head to toe. The only thing I really want to point out with this before we move on from it is, hold on. Okay, there we go. If somebody says they are hurting really bad in their right lower quadrant, and I know we've talked about this before, that needs to be the last place that you palpate. All right, so when you start poking and prodding, if they're complaining about right lower, then I would suggest hitting left upper, just because that's the farthest away from their pain. Then you catch your other side, your left lower, right upper, and then go to the right lower. All right, work your way toward the pain rather than starting there. Because if you poke and prod on somebody where they're already hurting, they're going to be hurting so bad they're not going to notice if there's pain, like a lesser pain anywhere else, especially not in an area as close together as your abdomen. Get your vital signs. All right, high respiratory rate with a normal pulse rate and blood pressure may indicate improper ventilations. Again, if they're hurting really bad, they're not going to be ventilating very well. They're going to be trying to breathe very shallow because it's just easier on them. If they have a high respiratory rate and the pulse rate with signs of shock, that may indicate that you're behind the curveball. And it's not necessarily your fault, but they may have waited to call 911, or the problem is so bad that it's coming on fast, right? And so they may already be getting septic or hypovolemic shock if they're bleeding out. So transport the patient in the most comfortable position. Like I said, usually it's the fetal. We get them to the hospital. If a patient has a dialysis shunt in his or her arm, avoid taking a blood pressure in the same arm as the shunt because you don't want to damage it. Now, I do want to say, hold on a second. Oh, never mind. We're going to get to it. All right, and then for your reassessment, the same as it always is. If they're critical, it's every 5 minutes. If they're stable, it's every 15 minutes. Although you can't treat the causes of acute abdomen, you can take steps to provide comfort and lessen the effects of shock. The big thing here, a lot of what we do is palliative care, which means comfort care. Even paramedics are going to be looking at how to make the pain less, because if they can lessen the pain, they can a lot of times bring a lot of the other problems back to normal. If their respirations aren't good because they're at a 20 out of 10 pain, then it's not the respirations they need to fix, it's the pain they need to fix. So kind of take that approach. Don't get so bent up trying to fix a number. Figure out why the number is not good and then take care of your patient. Treat the patient for shock even when obvious signs of shock are not apparent, because sepsis is actually not a shock you really come across. We used to, well, I'll say it this way. We just recently, as a profession, started really hammering down and focusing on sepsis because we kept missing it. EMTs, paramedics, even in the hospital, sepsis is the most missed form of shock that's out there. It's really hard to find it in the field. So a lot of times we're operating more on an educated guess that they might have it or the beginnings of it, because we can't run lab tests and stuff like that in the back of the ambulance. But what we can do is we can know what causes sepsis and we can know what the signs are of those causes and kind of get ahead of it, right? The hospital worries more about the lab results and the scientifically saying, yes, they have sepsis. We are more about knowing what can cause it and then trying to get ahead of the things that can cause it. Position patients who are vomiting to maintain the patent airway. That goes back to your primary assessment. Make sure that they have the ability and the will to breathe. Wear good PPE. When the patient has been released to hospital staff, clean the ambulance and equipment very well. Wash your hands and provide low flow oxygen. If they have nausea or anxiety, sometimes that helps, especially if they're not breathing very well. If they are insisting on doing shallow breaths, give them a little bit more oxygen just so that the breaths they are taking are still oxygenating them pretty well. Okay, so let's talk about dialysis, and I think, yep, that's it. This will be the last thing we cover for the night, so we are almost there. In patients with end-stage renal disease or chronic renal failure, dialysis is the only definitive treatment. Dialysis is basically taking the place of their kidneys, this filtering their blood. So a dialysis patient, when they go to dialysis, is going to go and sit next to a machine. They're going to connect this machine to these shunts that they have in their arm, and all their blood is going to flow through that machine and get filtered out. Um, they monitor their blood pressure to make sure that everything is copacetic for that. And I don't really know the details of how because I'm not a dialysis tech, but they go through, they filter out the blood and they get the potassium and everything. They don't take it all out because you do need it, but they take out excess. They have a way of monitoring those numbers and figuring out where they need to be. But here's the problem. Here's what you're going to run into as an EMT. So I'm probably going to get off the slides here a little bit. It'll be all right. Normally, when your patients go to dialysis like they should, everything is fine unless something goes wrong at dialysis, and that's a little different story. But as far as day-to-day life, a dialysis patient, as long as they're making their trips, they're going to be okay. The problem comes in when they don't make the trips. So that under that line of thinking, what do you think is the time of year? Is there a season basically that you might have more dialysis patients? Yeah, winter. We're getting into it. So y'all are going to finish this class in January. You're going to do the boot camp in January, and then you're going to start doing your ride-alongs around February. Maybe into January. Just depends. Y'all are the ones that set your ride dates. But you're going to be riding in the middle of winter. So some of your ride-alongs, you're probably going to get dialysis patients. So I mean, cool, because you get a lot of them. If you guys go to work on an ambulance every winter, you're going to probably get a bunch of them. So why not get it while you're in school too? But yes, you are. I don't know what you're talking about. Did I say something? um, but anyway, yeah, winter is. Yeah, okay. Oh, you're talking about when you get on the ambulance. So winter is a really big time for dialysis patients. So and even fall, because when people get sick, like say, a 55-year-old, well, we'll say 60s range person has dialysis. They're just getting over the flu or what they think is a flu, and we've got coronavirus going around like crazy. So people are feeling like they got run over by a truck for various reasons. They're not going to want to go to that dialysis appointment. And if they miss it, then they're going to run into problems like hyperkalemia or hypernatremia, where their potassium and sodium gets too high. And high potassium actually starts to mimic a heart block. All right, so they're going to start having cardiac issues, which is usually why they call 911. So you're going to get there. Your paramedics going to hook up a 12 lead to them and see what looks like a heart block. Um, but usually they understand, like if it's a dialysis patient, that's one of the questions they'll ask is, have you gone to your dialysis treatments like you should have? If you missed them, then what I'm looking at is most likely hyperkalemia. And there's a little bit that we can do for that in the field, but still, you're going to the hospital at that point. Um, yeah, I figured you guys that are already on trucks are gonna see these pretty regularly. But so just keep in mind that dialysis patients who don't make their dialysis treatments are going to wind up calling 911 because their electrolytes are out of whack in a way that mimics other issues, other scary, scary issues like heart attacks. Uh, the big thing I want you to know as EMTs, when you actually encounter these patients, is that when you are doing your job, so like checking their blood pressure or doing your assessments, take care to avoid the shunts. Don't put your blood pressure cuff over the arm that's got it. Use the other arm. Understand that they normally their pulse, their radial pulse will be okay. Like you're not going to notice a difference. But sometimes the problem is not that they missed dialysis. Sometimes the problem is that they have an infected shunt. So if there's a problem with that port, that can affect some things in their arm. So you may be checking their pulse or whatever, and you notice that the pulse is diminished on the arm that's got the shunt. That could be a couple of things, probably to do with the port itself. Can't fix them in the field, especially if it's a clot issue or something of that sort. But that's something that you can be highly aware of, and you can also pass that to your paramedic, because your paramedic's going to have some things that they can do when they suspect clots. So those are some things that will make you, I will say, a more valuable partner, and it also make you just a better EMT. Because what if you're on a basic truck and you're it? There's not a paramedic. Catching those things in advance can really help your patient out, because you'll recognize a need for ALS, or even if not that, you'd be like, all right, well, we got to go to the hospital. I'm not going to let you sign a refusal, that kind of thing. That's pretty much it. Some adverse effects of dialysis. I'll go ahead and read this. Hypotension, which is low blood pressure, muscle cramps, nausea and vomiting, hemorrhage from the access site. Like I was saying, if there's a problem with the ports, and infection at the access site. You see that a lot on new dialysis patients. They just got it in. The procedure, sometimes they wind up breaking their sterile field, and then now you get some infection growing there. It does happen. It happens a lot. But they try not to let it get too out of control. If you've got to take a dialysis patient, to the doctor or to the ER, there's really not a lot of it's a basic transport. You manage your ABCs, give them oxygen, let them sit comfortably, and transport them. If the patient's already in shock, then the fact that they're a dialysis patient is not your concern. Deal with the shock. And that's it for the night. Any questions on what we covered? There is more to the GI tract, but it's all from a trauma standpoint. We only covered it from medical tonight. So if you feel like something's missing and it's trauma related, then yes, it'll come next module. Nothing. Okay. All right. Your pin for the night is going to be B as in Bravo, C as in Charlie, 18, and the letter G as in golf. So BC18G. There it is written down. Any questions? Last chance. All right. Hey guys, have a good night. Catch up on your tests if you still have them. If you have more to catch up on, and I'll see y'all on Tuesday. Go ahead, Wesley. What you got? You can unmute. Actually, I will. No, I'll keep it recording.
Yo, can you hear me?
Yeah, I can hear you. What you got?
Hey, will I be doing the ride-alongs like with a paramedic and a basic, or will I just be doing the same thing I'm doing now?
No, they're gonna have to put you third on the box, so you're gonna ride along with the paramedic and the basic.
Roger, Roger.
Yeah, you can't. Unfortunately, even at especially at the paramedic level, and it makes sense, you can't be assigned to the truck and be a student, because if you get a call, you have to do your job in the role you're in. You don't have an opportunity to really watch the level you're going to.
It's gonna be like orientation all over again.
Yeah, pretty much. Just 48 hours, 4 12-hour shifts of hope you get something. Because I know, where are you wanting to ride? I mean, like, we obviously can put you on AAA, but do you want to ride in Hattiesburg where you get more calls, or?
Oh, dude, preferably. I'm switching to Picayune so I can get some more practical experience before that.
Okay. Yeah, that's a good. Picayune's pretty busy. I mean, I'm sure Chevy and then Renee would love to have you on the trucks.
I'm going to 104 with Mike Geske.
Oh boy.
Yeah. Hey, he teaches me pretty well though. So.
Yeah, no, he's a good guy. Mike's been around for a long, long time. So
Yeah.
his brother's over IT. Yeah, no, I know Mike. I know Mike from when I first became an EMT. Like he was an old paramedic when I got into EMS.
He's good people. He is old school for sure.
Yeah, he is. You got there's some people who just don't know how to take him. But yeah, he's a good guy.
Oh yeah, he'll holler at you.
while he's smoking a cigarette around the truck too.
Yeah, yep. All right, man. Appreciate it.
All right, dude. Take care.